Good morning, students. Now, let us learn about oxygen therapy. Why is it important? Oxygen is essential for normal cellular metabolism. In the absence of oxygen, the aerobic metabolism, which will provide energy in the form of ATPs, in the process of glycolysis with the usual Krebs cycle related aerobic metabolism results in 38 molecules of ATP. When there is inadequacy of oxygen, the normal metabolism is disturbed, wherein the pyruvate, instead of entering the Krebs cycle, it will go for fermentation, resulting in generation of only 2 molecules of ATP and lactates, resulting in lactic acidosis, and it is harmful to the body. So oxygen is essential for normal cellular metabolism. It's inadequacy that results in anoxemia. Hence, in order to prevent the tissue hypoxia, oxygen is supplemented, and this is called oxygen therapy. But oxygen should be used judiciously, meticulously, to prevent the harmful effects. Because injudicious use of oxygen at higher pressure leads to hyperoxia, leading to oxygen toxicity. Oxygen toxicity will also happen when it is used for the unproven indications. So, let us define oxygen therapy. Oxygen therapy is defined as the administration of oxygen from the sources, that is oxygen cylinder, pipe, supply from the pipeline, which will come from the liquid oxygen reservoir, sometimes from the oxygen concentrators, by various methods to relieve the problems with reduction in the oxygen content of the blood, that is anoxemia. What is anoxemia? Anoxemia is a severe reduction or the absence of oxygen in the arterial blood. This condition can result in loss of consciousness and brain damage. Then you must also know the term hypoxemia. Hypoxemia is a deficiency of oxygen in the blood. And this can be measured by the blood gas analysis to determine the partial pressure of oxygen in the arterial blood. Insufficient oxygenation leads to hypoxia. Oxygen therapy is indicated for acutely ill patient, and it is administered either from the environmental oxygen, which is available in the at 21%, by means of the device bag wall mask, or from the stored oxygen sources in a higher concentrations. Indications include low inspired oxygen conditions, when the inspired oxygen content itself is less, that's a high altitude. Poor tissue perfusion states like circulatory collapse, shock, inadequate or impaired hemoglobin carrying oxygen carrying capacity. It's anemia or abnormal hemoglobin, methemoglobin or methemoglobinemia and sulfur. Usually presents breathlessness, and as I mentioned, may be presenting with hypoxia in high altitude conditions with circulatory failure. Whenever the patient is critically ill, a patient will also require oxygen therapy when he is undergoing the surgery under anesthesia. Oxygen should be used as a drug. Let us understand with the tale of 4 patients, which I am going to explain. First, let us take an example of unresponsive gasping patient with dusky color. Second, patient with respiratory distress who is pale, cool, with moist skin, altered mentation, so that he is in shock. Third, patient with chest pain, moderate distress, his oxygen saturation is 90%. Fourth one, patient with chest pain, minor distress, the oxygen saturation of 96%. The first patient, it is clear that patient is in a respiratory failure. He has to be supplemented with oxygen. So, patient is in respiratory failure, he has to be supplemented with the oxygen. Coming to the second patient, patient is sick. Critically sick. It doesn't matter what his saturation is. He has to get oxygen supplementation by non-rebreathing mask. Third patient, his saturations are a bit low, and he will require the supplementation of oxygen, a minimum supplementation oxygen with low flow rate, which can increase his saturation level to 94%. You take the fourth patient, patient saturation is 96%. But his saturation is good. He is not in distress. He needs to be monitored carefully. If his saturation drops or the condition changes, we can respond promptly by supplementation of oxygen. Here, unnecessary giving higher concentration of oxygen will do more harm than good. So, oxygen is no more a wonder drug. It is a drug, but no more a wonder drug. It has to be used judiciously. It should be prescribed to a specific saturation range. The flow rate should be adjusted to achieve the targeted saturation. Patient should be frequently monitored, reviewed, and the target this one should be not more than 94 to 95%. Majority of the conditions, 94 to 95% is more than sufficient. Oxygen is not indicated unless the patient is hypoxemic or when he is critically ill. For a patient at risk of CO2 retention, that is COPD patient, the saturation level of 88 to 92% is more than sufficient. In COPD patients, like patients suffering from emphysema, chronic bronchitis, and asthma, it is hypoxia driven. So, if oxygen supplementation results in taking away this stimulus of hypoxia, which is essential for breathing, the patient will go for hyperventilation, which results in the hypercarbia, resulting in a coma and sometimes death. Oxygen is also contraindicated during atelectasis because it results in the oxygen toxicity. What are the different sources of oxygen? Oxygen can come from the cylinders, central manifold, or from the smaller cylinders, portable cylinders. Bulk of the oxygen supply for the major hospital will be from the liquid oxygen plants, PSA plant, oxygen concentrators, it can be delivered through cylinders or the piping. Oxygen delivery system involve low dependency, medium dependency, and high dependency delivery system. Low, the variable performance, fixed performance. Let us understand regarding these systems in detail in subsequent discussion. Low flow devices involve nasal cannula, nasal catheter, and transtracheal catheter. One with the reservoirs, they will provide variable performance output, which include face mask, partial rebreathing mask, or non-rebreathing mask, tracheostomy mask. High flow will provide fixed. High flow are also called fixed performance devices, which includes venti mask, high airflow oxygen enrichment mask, aerosol mask. So these are the different delivery systems. Okay. First one is a nasal cannula, wherein we can deliver oxygen up to 6 liters per minute, which can increase the inspired oxygen concentration from 25 to 40%. Usually low flows are preferred. Face mask, it will act as a reservoir. Here the flow rate of 5 to 10 liters per minute are maintained to achieve inspired oxygen concentration of 40 to 60%. The Venturi mask, a variable, the flow rate is maintained, and the flow oxygen at 2 to 15 per liters per minute based upon the valve. They will help to achieve the FiO2 of 24 to 60%. It is precisely controlled. When we want to achieve a higher FiO2 concentration, can use non-rebreathing mask. But the flow rate required for such delivery system is high, 10 to 15 liters per minute. However, if oxygen saturation is not maintained with non-rebreather mask, then we can go for the high flow nasal cannula. It is a specialized technique, specialized way of providing oxygen supplementation with humidification and heated and humidified oxygen supplementation in order to achieve almost 100% FiO2. But the flow rate of this oxygen should be about 60 liters per minute. So again, this shows different the devices through which we can provide oxygen supplementation. Low dependency. What do you understand by low dependency? In the low dependency, the patient is spontaneously breathing. Supplementation of oxygen alone is sufficient to correct hypoxia. Just supplementation of oxygen is sufficient to maintain this. No additional support is required. For a medium dependency, the patient is spontaneously breathing but requires additional support like a continuous positive airway pressure. So he requires supplemental oxygen and a degree of respiratory assistance. The high dependency, the patient spontaneous, this one is absent. So he will require either non-invasive positive pressure ventilation or invasive positive pressure ventilation. He wants the non-invasive or the invasive positive pressure ventilation because he is not breathing. We have to push the air rather than patient sucking the air. Supplemental oxygen and a full respiratory support is must. So what do you understand between low dependency and high dependency? Low dependency cannot deliver constant FiO2 inspired oxygen concentration. The flow rate is low, 6 to 8 liters per minute. Whereas in high flow devices, they will maintain, in case of high flow oxygen devices, they will maintain constant FiO2. they will require delivery of oxygen at a high flow. Higher flow rate is required. That means so higher flow rate of oxygen is required. For achieving low flow, a mixture of oxygen and room air entrainment can be used. For high flow devices, a higher flow of usually 4 times the actual minute ventilation is required. Low flow devices, FiO2 varies with the tidal volume. High flow devices, patient will depend on the hypoxic drive to breathe and require controlled increments in the FiO2. In case of low flow device, FiO2 varies with the tidal volume. Shallow breathing results in the less entrainment of the room air. Resulting in high FiO2. Deep and hyperapneic breathing results in the more entrainment of room air, resulting in less FiO2. Whereas in a patient requiring high flow oxygen devices, ventilatory requirement exceeding the capability of the low flow system. Hence, they will require treatment of a hypoxic patient with the increments in FiO2. Example of a low flow device includes oxygen cannula, oxygen mask, mask with the reservoir. High flow device includes jet mixing venturi mask, reservoir nebulizer, and oxygen plant. Common low flow. Now let us learn something about common low flow devices. Nasal cannula with prongs, nasal catheters, face mask, partial rebreathing mask or non-rebreathing mask, and tracheostomy mask. This nasal cannula involves the protruding, small protruding tubes from the main delivery tube, and so they consist of 2 soft prongs attached to oxygen supply tubing. A flow rate of 2 to 4 liters per minute is usually delivered to attain the FiO2 of 28 to 36 or 0.28 to 0.36. 1 means 100%. FiO2 attained is equal to the room air plus 4 times the oxygen delivered in liters. More than 6 liters will not achieve any benefit because the humidification of the inspired air is lost, and it will cause more harm. Here, nasopharynx will act as a reservoir. The patient breathes to the mouth. Airflow produces a Venturi effect in the posterior pharynx by entraining oxygen from nose. They are available in different sizes and different shapes from the pediatric to the geriatric patient we can use. So curved prongs for a proper anatomical fit. Flared prongs to slow down the flow of oxygen. Curved flared prongs combine the benefit of both the curved and flared design. Then straight prongs. Curved prongs with ear guards, improved anatomical fit and patient comfort. They are ideal for the patient in long-term oxygen therapy. Low weight, comfortable. Patient can eat, drink, and move. Cost is low. Disadvantage: cannot provide high flow oxygen. Cannot be used in nasal obstruction. FiO2 achieved varies with the patient's respiratory effort. High flow rates are uncomfortable. I am coming to the nasal catheter. Catheter is introduced into the nostril up to the uvula and helps to provide low flow oxygen therapy. Peculiarities of the nasal catheter include they can be single lumen catheter, which is lodged into the anterior nails, inserted just above the uvula. Oxygen flow is maintained at 2 to 3 liters per minute to attain FiO2 of 35 to 40%. It should not be used when nasal mucosal tear is suspected because of the risk of surgical emphysema. Deep insertion can cause air swallowing and gastric distension. Must be repositioned every 8 hours to prevent the breakdown. They are not having much advantage over nasal canal. Then you can use simple face mask. The oxygen will be additional oxygen will be supplemented to the oxygen inlet which comes from the oxygen source, and the patient can entrain the air through the ports, and exhalation happens to the holes that are present for the mask. Mask is transparent, provided with the holes, It has a reservoir of 100 or 250 ml. Different oxygen flow rates result in a highly variable and unpredictable FiO2. Rebreathing of carbon dioxide can occur with the oxygen flow rates less than 2 liters per minute. Four liters per minute oxygen flow delivers in FiO2 of 35 to 40%. Providing normal respiratory pressure. Flow rate greater than 8 liters per minute do not increase the FiO2. Advantages of a simple face mask include less expensive, can be used in mouth breathers. Disadvantage uncomfortable, require a tight seal, do not deliver high FiO2, that is inspired oxygen concentration. Inspired oxygen concentration varies with the breathing efforts, interferes with the eating, drinking, and communication, difficult to keep in position for a long time, chances of rebreathing are very high. Next, if the target oxygen content is not achieved, we can go for partial rebreathing mask, which involve mask with a reservoir bag of capacity 1 liter. Oxygen flows directly into the reservoir bag, which fills the oxygen flows directly into the reservoir bag, which fills during exhalation. Designed in such a way that it captures exhaled gases from the initial part of the expiration from the dead space. Useful in the situation where the supplies are limited. So here, during inspiration, the patient receives oxygen from the inlet as well as from the reservoir bag. During the expiration, initial part of this 1/3 of the expired gases will go and fill the bag. The remaining 2/3 of the expired gases are breathed out. So, partial rebreathing mask will deliver FiO2 of 60 to 80%. 5 to 8 liters per minute, or a minimum of 8 liters per minute should enter the mask to remove the exhaled carbon dioxide and to refill them. A minimum of 8 liters per minute oxygen should enter the mask to remove the exhaled carbon dioxide and to refill the oxygen reservoir. Flow rate should be sufficient to keep the bag 1/3 of half inflated at all times. It should not collapse. Advantages of the partial rebreathing mask include inspired gas not mixed with the room air. Air dilution doesn't happen. But patient can breathe room air through the exhalation ports if the oxygen supply get interrupted. This is the advantage. Disadvantage, more oxygen flow does not increase FiO2. Interferes with the eating and drinking. If the patient patient's hypoxia is not taken care of, partial rebreathing mask, then it is not attained. That means oxygen saturation is not attained to the acceptable level of 94 to 95%. Then next approach will be non-rebreathing mask. Non-breathing masks are provided with one-way valve between the mask and a bag through exhalation ports. FiO2 of 95% can be achieved with the oxygen flow rates of 10 to 15 liters per minute. Ideally, non-rebreathing masks should not allow entrainment of air. But because of the safety concern, one of the two exhalation ports is not provided with the valve. So in case of emergency, there can be entrainment of the room air. One-way valve. So 100% oxygen, listen and fills the bag. It opens during inspiration. Expired gases. Expired gases spilled out through the exhalation valve. Higher oxygen supply rates are required. If that is not maintained, there is a possibility of rebreathing carbon dioxide, which is detrimental. Best results will be achieved by adequate flow rates such that reservoir bag empties by no more than a third during inspiration. Best results are achieved by adequate flow rate 15 liters per minute, such that reservoir bag empties no more than a third during inspiration by best seal possible between the mask and the patient. Advantages: highest possible FiO2 without intubation. Non-invasively, we can maintain the FiO2. Suitable for spontaneous breathing patient with severe hypoxia. Disadvantage: expensive. Require tight seal, uncomfortable, interferes with eating and drinking. Not suitable for the long-term use. Malfunction can cause CO2 buildup and suffocation. So, to summarize, the various devices, how much FiO2 can be attained. It goes like this: nasal cannula, flow rate of 1 to 6 liters, FiO2 24 to 44%. Nasal transtracheal catheter 0.5 to 4 liters per minute can provide FiO2 of 24 to 40%. Oxygen mask, simple face mask, 5 to 6 liters, 6 to 7 liters, 7 to 8 liters can be provided, which can result in the FiO2 of 0.5, 0.6, 0.4, 0.5, and 0.6 respectively. Mask with the reservoir bag will require a flow, oxygen flow of 6 to 10 liters per minute, which can provide a FiO2 of 60 to 90%. Non-rebreathing, yeah. 10 to 15 liters will provide a FI out of 60 to 100%. Venturi mask, high flow, 13 to 15 liters per minute can provide FI out of 24 to 50%. High flow are the fixed performance devices based upon the Venturi principle, modification of Bernoulli principle. Gas flow is adjusted to meet the demands of the patient. Flow rate is adjusted depending upon the demands of the patient, not synonymous with the high concentration of oxygen. Plastic body of the mask with holes on both sides. Proximal end of the mask consists of a Venturi device. The Venturi device are color coded and marked with the Bernoulli principle. There will be fall in the pressure whenever this fall in the lateral pressure when it passes to the constricted portion, as a result of which there will be entrainment of the gas. And proximal end of the mask consists of Venturi device and color coded and marked with recommended oxygen flow rates. Alternative calibrated adjusted Venturi device can be used to deliver the FiO2. These are the various Venturi ports, the Venturi devices. Sorry, depend upon the flow rate, FiO2 can be achieved. Flow rate 2 liters per minute to 15%. They are color coded. Okay, orange 31%, yellow 35%. Adjustable, this one, the Venturi device can provide 35 to 60%. So also adjustable Venturi device can provide a 24 to 31%. Air entrainment delivers fixed concentration of oxygen. The size of the constriction determines the final concentration of the oxygen for a given flow. Size of the constriction determines the size of constriction determines the final concentration of oxygen for a given gas flow. A forward flow of the inspired gas increases the lateral pressure adjacent perpendicular to the vector of the flow increases, and resulting forward flow of the inspired gas increases the pressure gradient, increases the lateral pressure adjacent, increases lateral pressure the gradient, and the flow rate increases. Forward flow of the inspired gas increases. The lateral pressure adjacent and perpendicular to the vector of flow decreases, resulting in the entrainment of gas. Smaller the orifice is, greater the negative pressure generated. Smaller the orifice, greater the negative pressure generated. So more air entrainment occurs lower the FiO. FiO2 can be varying from 24 to 60%. Air dilution occurs, so the FiO2 falls. To the principle, the smaller pressure, greater the negative pressure generated. So more entrainment, air dilution occurs. So FiO2, the harmful effect of the higher FiO2 is reduced. Because of high fresh gas flow rate, exhaled gases are rapidly flushed. High fresh gas flow rate, exhaled gases are rapidly flushed from the mask via its holes. No, there is no rebreathing, no increase in the dead space. These masks are recommended when fixed oxygen concentration is desired in a patient whose ventilation is dependent on hypoxic drive. Where is the indication for this mask? These masks are indicated or recommended when a fixed oxygen concentration is desired in patient whose ventilation is dependent on hypoxic drive. These are color coded. Oxygen flow rate, you can oxygen flow rate variable from 2 liters to 15 liters. And in order to maintain the total flow, air entrainment occurs, and the oxygen concentration is maintained. Higher the air entrainment, and it will maintain the oxygen concentration. Venturi attachment with the reservoir tubing can be attached to tracheal tube also or supraglottic airway device as a part of the T-piece breathing system. Advantages: fine control of FiO2 at a fixed flow, fixed and reliable precise FiO2 supplementation. High flow comes from the air, saving the oxygen cost. Oxygen can be used for the low FiO2. It can be used for the low FiO2 also. It helps in deciding whether the oxygen requirement is increasing or decreasing. So advantages into fine control of the FiO2, reliable supplementation of the FiO2. High flow comes from the air, reduces oxygen cost. Help in deciding whether oxygen requirement is increasing or decreasing. Okay. Disadvantages: uncomfortable, expensive, cannot deliver very high FiO2, 24 to 60%. Interfere with the patient's activity, eating and drinking. If the patient oxygenation cannot be maintained with Venturi devices, then we have to go for high flow nasal cannula or invasive mechanical ventilation. This high flow nasal cannula delivers a heated and humidified oxygen by a special device called vapor. It will require higher flow rate. For even infants, 8 liters per minute of oxygen is required, and 40 liters in case of children. For the adults, up to 60 liters per minute. In patients with respiratory distress or failure, oxygen may be vinified. In patients with oxygen distress or severe respiratory failure, oxygen by the humidified high flow nasal cannula may be better tolerated than by the pacemakers. Patients with the respiratory distress or failure, oxygen by humidified high flow nasal cannula better tolerated than by the pacemakers. This is a special device used the heated and humidified oxygen will be delivered. High flow washes out the carbon dioxide in anatomical dead space. It has positive nasopharyngeal pressure. FI2 remains constant because gas is generally warmed to 37 degrees and completely humidified. Mucociliary function remains good and little discomfort is reported. This is a way of delivering a high flow nasal cannula supplemented oxygen therapy. For COPD patients and this one and long term, this one is required. We can use oxygen concentrator. Long term oxygen treatment in most of the low flow devices. Long term oxygen therapy devices include nasal cannula, reservoir nasal cannula, and transtracheal catheters. However, we should be cautious when we are delivering oxygen therapy because oxygen toxicity is associated danger when we do FiO2 higher than 50% for a period longer than 48 hours. Also, because this oxygen supports combustion, there is a danger of fire hazard. The usual complications of oxygen therapy, pulmonary and central nervous system. Progressive hypercapnia occurs if the respiratory drive is dependent on hypoxic stimulus. Inhaling of higher FiO2 causes hypoventilation, then hypercapnia, which is more common in the COPD patients. Because respiratory center becomes insensitive to hypercarbic drive. So FiO2 in these patients should be 24 to 30%. It can lead to absorption atelectasis. When 100% oxygen is administered in COPD patient, oxygen displaces all the nitrogen in the airway. Oxygen is highly soluble and this gets absorbed. And oxygen remaining in the airway gets fully absorbed, causing the alveolar collapse. Such changes occur within 6 minutes of 100% oxygen, leading to atelectasis. Drying and crusting of the secretions with the dry oxygen is additional danger. Cardiovascular complication includes the cardiovascular depression, because hyperbaric oxygen is a direct myocardial depression, especially in patients with sympathetic activity. Because release of hypoxia abolishes sympathetic overactivity, causing a hypotension and circulatory collapse. There is a fire hazard, so oxygen auditing should be carried out whenever oxygen therapy is provided. In order to reduce the cost, loss, and unnecessary hazards associated with the oxygen therapy. Oxygen toxicity also happens because of the free radical mediated injury. So, to summarize, oxygen is essential whenever there is an anoxemia or hypoxemia, and it should be used judiciously and depending upon the need, the oxygen should be supplemented from the low flow device, low flow delivery systems like a nasal cannula. If not attained the target level, then go for the face mask. We can provide the FiO2 of 35 to 60%. Still, if it is not known, you can this plan for non-rebreathing mask and fixed orifice devices, and in advanced respiratory failure, patient may be provided the invasive positive pressure ventilation or a non-invasive positive pressure ventilation. If it is not attained, then the invasive positive pressure ventilation with ventilators. In spite of in spite of all the various modalities of oxygen therapy, if the patient still suffers from the severe hypoxia or hypoxemia, we have to think about invasive mechanical ventilation with the support of ventilators to achieve the target oxygen content. To summarize, oxygen is one of the most commonly used therapeutic agent. It's used for broad range of conditions to relieve or prevent hypoxia. It should be used meticulously. The dose of oxygen planned with the partial pressure, planned targeting the partial pressure and the duration of exposure. Injudicious use of oxygen at a high partial pressure, hyperoxia, for unproven condition is known to cause potential oxygen toxicity. recent pandemic of coronavirus infection, COVID-19, has made us to understand the importance of oxygen use, oxygen therapy, oxygen administration. For that reason, this topic is selected to enrich your knowledge. If you are having any questions, you are invited. Thank you.